is a medical oncologist based in Dunedin. She's also a senior lecturer at Otago University and has previously worked at the Peter McCallum Centre in Melbourne. She has a genuine interest in NETs, and she not only presented yesterday at the nurses meeting, she's presenting for us today, which we're very grateful for. She's also hosting a meeting for ComNet's research group later today as well. So she's incredibly busy and we're really grateful to have you here. Thank you, Sharon.
Thank you. I suspect I'm not the only busy person here, Sharon. So thank you very much actually for arranging this meeting. I think what you guys have managed to achieve in such a short period of time for a small organisation is absolutely amazing. And I happen to be one of those people that's lucky enough to be able to do lots of things in my job. And one of the things that I've discovered I quite enjoy doing, kind of like research and like seeing patients, is actually teaching. So I learn a lot from the people that I see both in clinic and the students that I teach. But I will also learn a lot from being here with you guys today, so thank you for having me. So what I was tasked to talk about today, and I'm a wee bit shorter than other people, so we'll bring that down so I don't have to quite stand up so much, is, oh, and also I'm not talking loud enough. Hopefully we don't get too much feedback now. Is an overview of systemic treatments for NETs, and because we've got Professor Rod Hicks here today, I'm not going to talk about PRRT at all because he's got some much more amazing pictures than I can ever have. So firstly, some disclosures. My attendance here was funded by Novartis, but I think the more pertinent disclosures to make are that most of the drugs I'm talking about today are not funded in New Zealand or are only funded for certain indications. And in view of time constraints, because we've got half an hour, we're going to try and focus only on the treatments for which we've got randomised phase 3 trial data, and what that means is that the trials are of reasonable size and they had a comparison to another group, so we can actually look at what the differences might be in outcome in those. And I'm also not going to talk about side effects, and I think that's always important to think about when you're looking at a treatment whose aim is not to cure your cancer or take it away, but to try and control your cancer and help with your quality of life. So those are the caveats about what I'm talking about today. So firstly, a little bit about NETs, and this will be old hat to most of you, but I think it's useful to think about what they are when we're thinking about treating them. So they're a diverse group of cancers that arise from neuroendocrine cells, and normally the function of these cells is to produce hormones and peptides. And that means that for a lot of NET cancers, they can also produce hormones or peptides. Normal neuroendocrine cells exist pretty much all over the body, and that means that neuroendocrine cancers can arise pretty much all over the body. Neuroendocrine tumours also exist on a spectrum, from well to poorly differentiated, and generally the way that we measure this is using a grade, and that is assessed by looking down the microscope at the piece of tumour that the pathologist has got in front of them and looking at something called a Ki67, which is a stain that shows dividing cells or the number of mitoses they see down that microscope, and a mitosis is a dividing cell as well. This sort of spectrum of grade and differentiation means that there is a lot of diversity in biological behaviour, responses to treatment, and also prognosis within these tumours, and so we need to think about that when we're thinking about treatments as well. The more well-differentiated NETs are more like normal neuroendocrine cells, and so most of them have somatostatin receptors on their surface. The less differentiated your tumour gets, then the less likely it is to have those receptors on the cells, but the more likely it is to have rapid proliferation and high glucose metabolism, and we use those features for when we use our functional imaging. So really, in summary, what this means is that NETs are diverse, and because they're diverse, there are actually multiple treatment options and pathways. And treatments that will be offered will depend on where the primary tumour was located, the grade or the differentiation of the tumour, the stage of the tumour, whether it's functional or non-functional, and what symptoms someone has. I noticed that in your agenda today that no one was going to talk about local therapy, so I thought I'd put at least a slide in, because not everything that we do to treat neuroendocrine tumours is systemic. So some of you will have had surgery, some people would have had external beam radiotherapy, and there are a number of liver-directed therapies that we can use, particularly to help with symptoms. So that's just to know that they're there, and I know that your neuroendocrine tumour patient booklet has some more information on local therapies in it as well. So on to systemic therapies, and I've put observation in there as well, because observation is something that we do to all of you, so I consider that to be a systemic therapy. Then we're going to talk about somatostatin analogues, which our dietitian earlier today has mentioned briefly, things called targeted therapies, chemotherapy, and then Rod's going to talk about PRRT in the next session. So we're going to start with somatostatin analogues, and we're going to start with a definition. So somatostatin is a hormone that binds to somatostatin receptors. So those are the receptors that are on normal neuroendocrine cells and the more well-differentiated neuroendocrine tumours. An analogue in the setting of a molecule is a compound with a molecular structure similar to something else. So somatostatin analogues are things that look like somatostatin. The other thing to realise is that there are 5 somatostatin receptors that we know about at the moment, and they are labelled 1 to 5. There are 2 main somatostatin analogues that are in use. The one that's funded in New Zealand is sandostatin, and there's another one called lanreotide, and they're both depot injections, so they're long-acting, and people will generally start on having an injection every 4 weeks. These have a high affinity to the somatostatin receptor 2 and a bit of affinity to somatostatin receptor 5, and there are some other somatostatin analogues out there that have a greater affinity to other somatostatin receptors, but not so much information on them yet. Initially, these drugs were used to treat hormone symptoms or symptoms from hormone production or release by binding to those somatostatin receptors and stopping that release. But more recently, as our dietitian referred to earlier today, these have also been shown to delay tumour growth. And these are the 2 studies that sort of showed that to us. And what you discover about clinical trials, if you start looking at clinical trials, is people like to have fancy acronyms so we can remember what the studies are. And the ones that we're talking about here are something called PROMID and something called Clarinet. The PROMID study looked at sandostatin LAR, whereas the Clarinet study looked at lanreotide. Both were given 4 weekly, and both studies involved a comparison to a placebo, so something that looked the same but didn't have any active ingredient in it. The populations that were involved in these studies were slightly different. So PROMID looked just at midgut nets, whereas Clarinet also looked at GI and pancreatic nets. You can see the PROMID study actually was reasonably small. The Clarinet study was a bit bigger, and they also looked at different differentiations. So in PROMID, it was just grade 1 tumours, so Ki67, that's that marker that we look at on histology to see what grade a tumour is of less than 2%, whereas the Clarinet study included tumours that had a Ki67 of less than 10%, so slightly different populations. The graphs that we've got on the bottom here are Kaplan-Meier curves. Now, just in case someone's not familiar with what these are, I'm just going to walk through them because this is what we use to visually look at the results of clinical trials frequently. So what they're doing is giving a visual representation of the proportion of patients in different groups that have had an event. So the time is usually given on the horizontal axis, and in both cases here we've got time in months. And then the proportion of patients that have had the event is on the vertical axis, and the event can be different. So that's one of the things you need to look at when you're looking at the graphs. So in the PROMID study, they measured time to progression, whereas in the Clarinet study, they measured progression-free survival. So very similar things, but measured in slightly different ways. What they then graph is, and on the bottom what they show is the number of patients that are at risk at each time, and you can see that at each time point the number of patients that are at risk decreases. So not everybody in these trials has had follow-up to 78 months in the PROMID study or to the 27 months that was in the Clarinet study. So once your follow-up time has finished, even if you haven't had an event, your data gets removed from that because you're no longer at risk of that event. And that's why the number of patients along the horizontal axis gets less. And every time a patient has an event, they become part of the proportion of patients that have had those events, so you get a step down in the graph. The different groups get different colours or different ways of describing their curves. So in both of these trials, the blue curve is the patients that had the placebo, so the non-active drug, and the yellow one on the pyramid is the patients that had octreotide or sandostatin LAR, and the red one is the lanreotide group in the clarinet study. And you can see that less patients over time had the event that was looked at with the somatostatin analogues in both trials. And they do statistics to try and determine the magnitude of that effect. And the way that you look at that generally is something called a hazard ratio. And the hazard ratio is kind of describing the risk of that event. If the hazard ratio is 1, then there's no difference between the two groups. If the hazard ratio is greater than 1, then the comparison group has a greater risk of that event than the control group. If it's less than 1, then the comparison group has less of a risk of that event than the control group. Make sense? Kinda? I hear some no's. Sorry. So the hazard ratios in both of these trials was less than 0.5. So what you can kind of take away from that is there's a 50% decreased chance of the event, which was progression, by using these medications with these subsets of tumours. Unfortunately, in neither trial did we find an overall survival benefit, and that was because crossover was allowed. So that's the somatostatin analogues. One of the things that these trials also show us is that observation is actually a legitimate treatment choice for some patients, because if we looked at the patients in the placebo arm from the clarinet trial, the average progression-free survival, so the average time to progression in that study for someone who was not having an active treatment was 18 months. And in that trial study, more than, I think, 96% of patients hadn't had progression in the 3 to 6 months before they were enrolled, documented into that. So that's kind of like 2 years of nothing happening. And when you think about any treatment that you have, there are actually potential side effects. So if you have no symptoms and if your disease is stable, and particularly if one of the side effects from the treatment that's been offered or is available is something that may make you more unwell because of generally what we call competing comorbidities, so other illnesses, then it's a legitimate choice to not have treatment for a period of time. So, next thing we're going to talk about is targeted therapies. And targeted therapies, a really simple way of thinking about them is these are drugs that stop cancers growing and spreading by targeting specific genes or proteins that that cancer is using to make it grow. So technically, somatostatin analogues are targeted therapies because they are targeting the somatostatin receptors. There are some other targeted therapies that have been shown to have efficacy or evidence of benefit in some NETs, and those include everolimus and sunitinib. The first one we're going to talk about is everolimus, and both of these drugs, by the way, are tablets. Everolimus is something called an mTOR inhibitor. This is the molecular pathway that mTOR is involved in, and it's a protein complex that is involved in cell metabolism, cell growth and proliferation, so things that if you're a cancer it's good to upregulate to keep yourself growing. So if you have a cancer where this is part of the pathway that's involved in keeping that cancer going, then blocking it should hopefully stop that cancer growing. Again, we have a nice acronym for the trials that have been used to look at everolimus and NETs, and that's RADIANT. And again, these trials have shown some benefit in terms of progression, but not overall survival again. And that benefit has been shown in pancreatic, lung and GI NETs, and those that are grade 1 and grade 2. So on to some more Kaplan-Meier curves, but we know what these look like now. The trial on the left-hand side here was one that looked at pancreatic NETs. The trial on the right-hand side looked at lung or GI NETs. And both of them had a placebo arm, so the patients that weren't on the active treatment got something that looked like it but didn't have a drug in it. And all of the patients in these trials had evidence of progression before they were enrolled. And again, what we can see is that the blue curve, that's the everolimus curve, in both cases sits higher than the red curve of the placebo, so we can see that there's some benefit there. And if we look at the hazard ratio, again, both of them are less than 0.5, so there's a 50% decrease in chance of the event that's been looked at, which is progression-free survival, and with the use of everolimus in these subgroups of NETs. Sunitinib, as I said, is also a tablet, and this is something we call a multi-targeted tyrosine kinase inhibitor, or a TKI. Tyrosine kinases are receptors that sit on the outside, or on the cell membrane, and they're sort of the gatekeepers to pathways inside the cell that help with cell growth and proliferation. Sunitinib is one of those tyrosine kinase inhibitors that blocks multiple of these tyrosine kinases and has shown efficacy in a number of different cancers. And this is one of the few drugs that we have that has actually shown an overall survival benefit, but that's just been shown in pancreatic NETs to this stage, and that was in this study here. So these are the Kaplan-Meier curves from that study that was published in 2011, and the one on the left is looking at progression-free survival, the one on the right is looking at overall survival. Again, just pancreatic NETs, and again, just the well-differentiated ones, so grade 1 and grade 2, but an improvement in both progression-free and overall survival with the use of this drug. So, on to chemotherapy. Now, there are multiple agents and regimens that are used in neuroendocrine tumours, and we're not going to go into all of them, mainly because there's not actually a whole lot of strong evidence that tells us what's the right one to use. Chemotherapy, in a really simple way of looking at it, is it kills cancer cells by stopping cell division. So not really targeted like targeted therapies, but effective more in cells that are turning over faster, which means it's more effective in the less differentiated neuroendocrine tumours, or in neuroendocrine carcinomas if we're going to use the appropriate terminology. So the ones that are dividing quickly, and these end up being our first-line therapy, particularly in New Zealand, for patients with the poorly differentiated or grade 3 NETs. There are, because this is an area where we don't have a whole lot of evidence, a bunch of clinical trials that are happening at the moment, and I'm going to show you some of those as a way of showing how much effort and how many things are actually happening in this space to try and figure out what we should be doing for different patients with different types of NETs. So this one is looking at just grade 1 and grade 2 pancreatic NETs, and we don't really know what's the best chemotherapy that we should be using for these less quickly dividing tumours, so the slower growing ones. And some of you may have heard of the drugs that are looked at here, so temozolomide and capecitabine. And so one arm's just looking at temozolomide itself, the other one's looking at the combination. One thing to know is both of these drugs are funded for these indications in New Zealand. So if this trial gives us an answer, we can use these drugs without having to lobby Pharmac to give us something new at this stage. This is the first randomised controlled trial in neuroendocrine carcinomas, and I think that that's quite amazing. And it's looking at really the two frontline chemotherapy regimens that we use in this setting, so that capecitabine temozolomide combination, and then a platinum etoposide combination. And they're also going to do something really lovely, which is try and figure out where our optimal cutoff is. So at what point in time do we think that this one is going to be better than this one? So what order should we be giving these to you in? And again, both of these drugs are also funded in New Zealand. So when these trials give us answers, these are things that we can use without having to do any lobbying. We can use them straight away. Just so we can have something a little bit more local, the Control NETs trial is one that's been run by the Australasian Gastrointestinal Trials Group. Unfortunately, it's not a trial we can be involved in New Zealand at this point in time because we don't have PRRT. But what this trial is trying to do is figure out whether PRRT by itself or the combination with chemotherapy is the best thing to do for different types of NETs, because as well as us being aware that the differentiation of a tumour determines its chemosensitivity, we also think that where a tumour's originated can determine its chemotherapy sensitivity. So there's lots of things we don't know, and that's what these trials are trying to help us out with. These are all ongoing, so these are trials that will hopefully give us answers in the next couple of years, and that can then help inform the treatments that we're giving. So I'm just going to finish with this slide. Because neuroendocrine tumours are so diverse and individuals are diverse, really the treatment for neuroendocrine tumours needs to be individualised and involve a multidisciplinary team. And what is happening this afternoon, again, like happened last year, is that there will be a multidisciplinary team meeting, and you can see the process that happens there. The other thing to remember is that what your tumour's doing changes over time. So what will be the right treatment at this point in time may change as time goes on. And so this is an evolving field, but it's also evolving within you. So hopefully we've covered things so that you have a little bit of an idea about what's going on.